the studies, which are controlled randomized studies that we have with Mars. However, if you look at the PubMed, you will see more than 200 papers covering different aspects, different indications, different papers, patient populations, which compares quite well when you look at some, let's say, alternative liver support devices like the Prometheus system or the SPAD system. The indications for Mars are quite varied. However, the main data we have is especially in acute and chronic liver failure and acute liver failure. However, we have data, we have experiences in some other indications like graft dysfunction after liver transplantation, liver failure after hepatectomy, secondary liver failure, or intractable pruritus. We also have some contraindications, and this is very important to highlight that patients at the very late stage of the liver decompensation should not be considered for Mars because it could be so late. So we strongly recommend to avoid the therapy in patients that have already developed uncontrolled sepsis or septic shock, that have a severe coagulopathy with DIC and so on, fibrinolysis, patients that have a platelet count below 50,000, patients that have acute hemorrhages, or patients with a very unstable hemodynamics with a mean arterial pressure really low. Just to finish that, I just would like to refer to two slides that were presented 1 year ago at the postgraduate course of the meeting of the American Association for the Study of Liver Diseases. In this postgraduate course, the speaker was asked to really focus which would be, let's say, the role of a liver support device in the two main indications, acute liver failure and acute and chronic liver failure. Basically, what the speaker said is that being an acute liver failure, very well-defined diagnostic criteria and clear impact on mortality, etc., you can distinguish between those patients who are transplant candidates versus the ones who are not candidates. The role of a liver support in the candidates to transplantation would be to decrease the on-list mortality, to decrease the complications, to improve the hospital outcomes, and in some cases, avoid unnecessary transplantation procedures because of the capacity sometimes of the patient to recover. While in non-candidates, it would be the survival increase. On the other side, on acute and chronic, which represents a very heterogeneous group of patients, also you could identify, potential candidates than non-candidates. For the potential candidates, the role of a liver support would be to bridge to transplant, to allow the patient to remain stable until the graft is available, and the non-candidates would be the survival increase. The conclusion is that Mars has been used since 1999 in more than 15,000 patients, 50,000 single treatments in 250 centers in the world, which represents about 45 countries. The indications are the ones I already explained to you, both in adults but also in pediatric cases. The system successfully removes both albumin-bound and hydrosoluble substances. The clinical effects, as we have seen, include the improvement of hemodynamic, cerebral, kidney, and liver function. The increased survival in Mars group could be demonstrated in some few randomized controlled trials. However, from the Gambro point of view, we are still committed to continuing the development of the clinical and technical applications of the system. And I would like to thank you very much for your attention. Shukran.
Thank you, Professor Turner, for this elegant lecture. Please stay with us in order not to interrupt your thoughts about this talk. Professor Ashraf Dahaba, Professor of Anesthesiology and Intensive Care.
I'm Professor Ashraf Dahaba, as Professor Khadr kindly introduced me, and today I will use the last remaining 3 minutes just to highlight and to focus on something. 3 minutes, 2 or 2 minutes just to highlight, or even 1 minute, just to highlight and focus on some of the aspects which Joseph kindly presented to us. As he kindly explained, Mars can improve many of the things which go wrong with the liver failure. One of the things which we concentrated upon in my university in Graz was looking at the hepatic encephalopathy. We did, first of all, the hepatologists don't have an objective monitor to quantify the hepatic encephalopathy, unfortunately. So they have the West Haven criteria, but other than that, they don't know how to quantify it. We have a monitor which is called bispectral index, which is an EEG-derived monitor. This we can successfully use to quantify the hepatic encephalopathy West Haven. This is my daughter, first of all, and I promised her that I have to show her photo in every presentation I have all over the world, and she's my little panda. Actually, she was born in the Sichuan province near the panda. This is my other daughter. And I'm sure you will be asking, why do we need the Mars or whatever industry? But this is a quotation from Mao Zedong. He said, Yongui Chongyong. That means we take what is useful for us. So if you see it's a useful monitor and it can serve your patients, you can use it. Very quickly, these are the EEG changes with the different 4 groups of West Haven. They move between alpha, beta, delta, theta. This we can change with the bispectral index into a dimensionless number. 100 is fully awake. We should be all 100. Unless my presentation is very boring, then you will all drop down to 40 or 30. But what we did is we validated the monitor. We validated the monitor to quantify hepatic encephalopathy. And then we found out that between 85 and 70 would be West Haven grade 3, which are patients who are a little bit confused. And above 85 are West Haven grade 1, which are patients who are awake but a little bit slow. And between 70 and 55, this is 3, which are pre-coma. And the patients below 55 are the patients who come to us in coma. What I wanted to present today is that all of these patients had hepatic encephalopathy. When we looked at them using the BIS, we suddenly found a very peculiar phenomena. We used the Gambro. This is first what we found in the first patients which we used the BIS. As you can see here, at the beginning, you can see that the patients all come to us with a BIS of 40. This is the beginning. I don't know how to use this pointer. The pointer? Not pointer. Oh, yeah. Here, at the beginning, as you see here, these are the patients coming to us with hepatic encephalopathy and BIS as low as 40. And once you put the Mars, the patients start to recover. But the so peculiar thing in these patients is they did not recover gradually. So what Joseph just presented here, if we are looking at the fractioned amino acids or aromatic amino acids, if you are looking of all the things which are improved by the albumin separation, if you are looking at the ammonia, if you are looking at removing of the bile, if you are looking at hemodynamic stability, they all happen gradually. We expected that the hepatic encephalopathy also would recover gradually, but actually it did not. As you see, we have a very strange phenomena here because the first 2 hours, the patients stay at West Haven 4. They stay at BIS around 40 for almost 2 or 3 hours. Then they suddenly recover to a next stage, to stage 3, and they stay there. And then after 2 hours, then they suddenly recover to West Haven grade 2. This is repeated in almost every patient. As you see, this patient stays in West Haven grade 4, which is coma, and then suddenly he recovers to the next stage, and then to the 3rd stage, and then it becomes very evident when we repeat it again and again and again. We have seen this very strange, very peculiar recovery of the encephalopathy, not a gradual recovery, but a stepwise recovery. As you see, one stage, he stays below 60, and suddenly he recovers above 60, and then suddenly he wakes up and he starts talking. I talked with all hepatologists and nephrologists, because this we do in the nephrology department over there. Is there a certain threshold of any of the toxins which we can remove, which can affect the hepatic encephalopathy, or any physiological phenomena, vasoactive nitric oxide or whatever, that does behave not in a gradual fashion, but in a stepwise fashion? And the answer from all of them was an absolute no. So up till now, we are planning a multi-center study, trying to look, can we repeat this in every and almost all the patients that we have? And I'll be more than happy to get your input and your suggestions of what happens in the brains of the patients with liver disease that behaves in a stepwise fashion and not in a gradual fashion when you are doing liver separation, liver albumin separation. Thank you very much, and I think we have still 2 minutes for
Thank you.
for a discussion.
Thank you for this elegant 2 talks. And now the first question will be from Dr. Gamal Madi.
Thank you for this interesting presentation. Professor Dr. Joseph, regarding the procedure of the MARS, how long the session of the dialysis?
How, sorry?
How long? How many hours?
Yeah. In principle, our recommendation, which is based on the experience in most of the studies, is that we recommend sessions between 6 and 8 hours. Because we consider that, especially in patients with acute and chronic liver failure, it's more or less the time that the absorber cartridges that clean the albumin get saturated. However, if the patient with liver failure has concomitantly, renal failure, you could continue and extend the therapy beyond 12 or even 18 hours, because even though when the cartridges get saturated, you still can do renal replacement therapy.
Yeah, for hepatorenal syndrome.
Yeah.
Yeah, and the amount of albumin consumed during the session?
Yeah, the circuit has to be filled with 500 milliliters, half a liter, of albumin at 20% concentration.
Yeah. Any cases of, after the session or during the session of disequilibrium syndrome happened?
Sorry, I couldn't.
Disequilibrium syndrome? The patient developed disequilibrium syndrome after the dialysis?
Oh,
that's what happened, yeah. Like what happened for renal dialysis?
It's a syndrome which happens when you do the
Yeah. No, we have not seen any sign of disequilibrium. Yeah, I know what you are talking about. Sorry.
Yeah.
No, but we have not seen.
The patient already has brain edema from the beginning.
Yeah, probably because the way that the removal of these substances is produced, it's quite slow, and we have not seen any, let's say, side effect of complications based on this concept.
If I may add, just one quick remark. Regarding the disequilibrium syndrome, actually we ran another study which is about to be published using the bispectral index in the first time hemodialysis, not liver dialysis. And we have found, we expected that the patients would come to us from the uremia with the bispectral index low, like the liver patients, and it would recover after the end of their hemodialysis. But also again, strangely enough, we found that the patients who come to us for the hemodialysis, the BIS is almost normal. They're fully awake, although they are uremic. And at the end of a quick session, the BIS goes down.
Yeah.
The only explanation we could have, an explanation, was disequilibrium syndrome, disequilibrium dialysis syndrome, because their brain is a little bit changed, and this
the rapid
was
correction
the opposite.
Yes.
Thank you.
Again, regarding patients with spontaneous bacterial peritonitis, any role for removal of the bacterial toxins by this MARS? Peritonitis, sepsis?
Yeah, well, when a patient has a spontaneous bacterial peritonitis, I don't think that this should prevent the MARS therapy. However, what our recommendation is to start the therapy providing the patient the adequate antibiotic treatment. So because the risk in these patients who have very immunodepressed to move from a SVP to sepsis is very high.
The patient's usually hypotensive. How can you control this?
Well,
during the
I mean,
it's difficult to extracorporeal circulation and.
No, the very interesting thing is that the same as the effect on hepatic encephalopathy, the effect of improving systemic vascular resistance and mean arterial pressure in these patients is very quick. So in general, even in patients that are under vasoactive drugs, the use of the therapy sometimes allow you to reduce the doses of these vasoactive drugs, or even, let's say, stop using them, because either by the removal of nitric oxide, which is the main theory, or other substances, it has really a clear, direct, and quick effect on improving hemodynamics.
Thank you very much.
Final question from Dr. Muntasser, because of short of time.
Thank you, Dr. Joseph, for your elegant lecture. but I have a question as regards the different studies in liver dialysis. It shows clinical and biochemical improvement, but the survival benefit is not that much at the same level. What is the explanation for this?
Well, you know, I mean, this is a question that it's difficult to answer. I mean, it's true that I agree with you that there are a number of studies showing an improvement of surrogate markers of survival, and that the only studies on improvement in survival have been in small studies. However, you know, those studies that you are talking about probably is the ones on acute and chronic. And then right now in the hepatology community, there is a very strong, let's say, initiatives to understand better acute and chronic. The point is, the main aspect is whether you know, we apply the therapy a bit too late, or whether, you know, the doses of the therapy should be increased towards a more, let's say, intensive treatment, or you know, maybe you should look at different endpoints, like for example, bridge to transplant, because at the end, especially in patients with acute and chronic liver failure, I mean, you cannot expect a sustained improvement of liver function in the mid-long term, but only, let's say, in the short term to allow the patient for a bridge to transplant. You know, different is the case of acute liver failure, in which you could stimulate the capacity of the liver to recover. And we have, you know, one interesting study that I showed before on acute liver failure, in which, you know, basically we did not hit the survival improvement because, you know, 2/3 of the patients were transplanted in less than 24 hours. And then, you know, you cannot establish the difference when in both groups the majority of patients are transplanted.
Thank you.
Just
Okay. I think there's
Announcement, your announcement?
or
Yes.
a question first. Take a question.
Thank you for this lecture. My question is regarding the frequency. How many times a week we should continue this dialysis? Is it as in renal dialysis? First. Second is in case of severe hypoalbuminemia. And we know this is, its mechanism is adsorption and take the toxins bound to albumin. But in case of severe hypoalbuminemia, what about the other toxins? And there is also albumin in case of hepatic encephalopathy.
Okay, thank you. The first question is that, you know, right now, as Mr. Chairman said, you know, we are still, you know, in the infancy or adolescence of the therapy. And up to now, basically, the therapy has been addressed to patients in acute, either acute or acute and chronic. So we still do not have, let's say, enough data to support the use of the therapy in the mid-long term. We only have, you know, some case reports of patients, especially children, that has been kept, let's say, alive, stable for months until they were finally transplanted. So we will have to wait. You know, the same way that in renal dialysis, you started by the acute indications and later on you move to chronic indications. In terms of the hypoalbuminemia, well, you know, the majority of patients with liver failure have hypoalbuminemia. So what happens then is probably many of the substances that should be bound to albumin are free in the blood. But this does not prevent, even, you know, can facilitate, let's say, the captation or of the pass of these substances through the membrane and being bound to the extracorporeal albumin.
Thank you.
So thank you, professors. And because of lack of time, we will move to the second speaker, Professor Dr. Maher Fouad, who will speak about hepatitis C and transplantation, please. Meanwhile, there's a small announcement from Dr. Ashraf.
Okay, a quick announcement. Today at 6 o'clock in Alhambra, -2, we will be presenting and discussing how to publish, how to write, how to conduct, and how to design a study